for joining us today. We are very excited to offer another webinar series for 2014. This year we will have 12 webinars, one every month. Some of the webinars will be designed for healthcare professionals and others will be for a wider audience, including helpful information for those affected by a brain tumor. And we will have all of our webinars listed on our website. Today marks our second of 12 webinars this year with Dr. Brenda Sabo, joining us from Halifax. Dr. Brenda Sabo, an associate professor with the School of Nursing at Dalhousie University, where she teaches oncology nursing and research. She is also a psychotherapist with the psychosocial oncology team, Cancer Care Program Capital Health, where she sees patients and families living with and affected by cancer across the continuum from diagnosis to end of life. Her research focuses on psychosocial issues, depression, anxiety, and trauma, affecting patients, spouses, caregivers, professional and lay, arising out of the cancer experience. She has been funded at the local, provincial, and national level for her work. Dr. Sabo has numerous publications in this area and currently has an article in review focused on this couple relationship, preferred coping style, and distress on adapting and quality of life following a diagnosis of a primary malignant brain tumor. I also want to add that Dr. Sabo has spoken for us at various programs and conferences, including our annual Halifax Brain Tumor Information Day, our annual Halifax Healthcare Professionals Workshop, and she's also now the facilitator for our Halifax support group. So we keep her busy, and I would like to welcome Dr. Sabo, and I will hand it over to you.
Thank you very much, Janique. I sort of laughingly thought that everybody must be tired of hearing from me these days.
Not at all.
Anyways, I really do appreciate the invitation. So today's focus is really on how to enter into those difficult conversations with patients and families, the ones that tend to make us uncomfortable, and recognizing and acknowledging that avoidance really is not a strategy because it doesn't help anybody, including healthcare professionals. So the objectives for today's presentation is to identify the critical conversations that are often avoided by healthcare professionals, highlight some of the implications when these issues are not explored with patients and families, and look at some possible strategies to help engage in conversation. Now, recognizing that this really is just an introduction to things and that there are certainly much more involved strategic approaches that actually take more than an hour to learn and to practice, and role-playing is certainly one of the ways that we can learn to become better at having those kinds of conversations, and those are usually the things I do with students or when I'm giving workshops. So, I'm going to, can I, sort of unique, I can shrink this screen down? That's down the side?
You should be able to,
there,
yeah.
Okay, I've moved. Well, it's still there.
The GoToWebinar screen?
Yeah.
There's a little red arrow you should be able to click.
A little red arrow?
To click it to close.
Oh, hang on. I'll just do this. Oops, are you sure you want to leave? No.
Nope.
Oh, there we go. Something happened. Sorry about that, folks. Technology is not my strong suit. So what do patients and families want? They really want clear information about the disease process, symptom management, prognosis, treatment options, information around sexual health, and end-of-life care. So a wide range of things that they really want information on. They want a communication style that really involves empathy and hope. So it's really about connecting with them, not displaying that you're in a rush or anything, and that they are important. When we have those conversations, perhaps the biggest challenge is around balancing information. How do we ensure that we support hope, and yet they have the information around the reality of? We do not want to instill a sense of false hope in individuals. And so it's a fine line that we, as healthcare professionals, I think, tread. And sometimes we can get caught up in the whole notion of prognostication and numbers. And I've certainly, from patients and families, heard from, on a number of occasions how healthcare professionals, and this is across the board, I'm not singling out any one particular group, particularly in the advanced brain tumors, that numbers, particularly overall survival, features prominently. And while I understand the need to provide that kind of information when it's repeated every time an individual shows up for a meeting with their specialist, the nurse, or another healthcare professional, that really does little to support hope. And then the other thing that patients and families want is a safe space within which to discuss their fears and concerns. So what do we know? This is from the literature. We know that healthcare professionals acknowledge 57% of socio-emotional cues. They only respond to 22%. They engage in blocking behavior when they feel they lack the confidence in the ability to address emotions. And this certainly is understandable. If you don't feel comfortable, if you don't feel like you have the appropriate skill set to have the kinds of conversations, it's probably easier to avoid them. And I think there's a tendency to think that, well, if I don't have the confidence, if I don't feel I can enter into that conversation, I might say the wrong thing and make things worse. I can certainly tell you from clinical experience that I don't always have the answers. I certainly, from time to time, make mistakes, but as long as I have created an environment within which the patient or family member who has come to see me feels trust, they feel that I'm very interested in what it is they have to say, I can stick my foot in my mouth. They'll certainly tell me that I've done it, and we can move on from there. And I certainly can learn from the experience. Healthcare professionals have a tendency to focus on the physical aspects of care. This is probably more likely to take place when one feels like they aren't adequately prepared to have the kind of communication that the patient and family wants, particularly around psychosocial issues, end of life, or sexuality and sexual health. Some studies have actually identified that up to 80% of patients would like to have conversations around spirituality, around sexuality and sexual health, but probably less than 10% of healthcare professionals actually have those kinds of conversations with them. We know that the healthcare system and healthcare professionals have a tendency to engage in death-defying mode. What we mean by this is that our healthcare system is very much a biomedical model, which has a focus and an emphasis on cure. And so you're going to go to the ultimate or nth degree to ensure that some form of cure takes place, and we feel we've failed if a disease advances and a patient needs to be transferred to palliative care. Patients often do not know about their palliative status until they're referred to supportive or palliative care. So there's a lack of appropriate transitioning and communication around that transition. I've actually got a study, there's a large team of us putting in to explore facilitators and barriers around early transitioning to palliative care. And part of it will include a focus on attitudes, values, and beliefs held by healthcare professionals around end-of-life, advanced care planning, and transitioning to supportive palliative care. While we do have wonderful programs across the country, we know that these are not being accessed. Actually, there's some data from an end-of-life study from a group of colleagues here in Halifax through the Network for End-of-Life Studies that has identified some discrepancies, and these include 39% were not told what to expect when they approached death. 59% of those who died, and these are talking to the caregivers, did not know what to do at time of death, and 27% did not have information about medications and symptom management. I mean, that's particularly glaring when we think about the issues that many of our patients face, and the lack of communication continues to be suboptimal. Research also suggests that 35 to 45% of individuals experience moderate to high levels of distress. Anxiety and depression perhaps predominate. Some adjustment disorders can be factored within that. And there's a small percentage, probably between 4 and 7% of patients that may actually experience post-traumatic stress as a result of their cancer experience. Physicians and nurses often under-recognize depressive symptoms as normal reactions to life-shortening illness. When somebody's told that they've been diagnosed with cancer, they get tearful, but it's important to look at what's behind these symptoms and that they're not always normal. Certainly a component of grief when you're just told that you've got cancer, I would consider to be a normal response. But it certainly behooves us to touch base with our patients, and in particular the family members who are the primary caregivers, around how are they doing. Cancer care systems, for the most part, still have a long way to go around addressing patient distress. Certainly psychosocial distress is now considered the 6th vital sign, so it's important that we actually assess for that within the cancer care population. What we still don't do is assess our family caregivers, and they may experience greater levels of distress than patients themselves. So what else do we know? We know that family members often don't want to talk about their emotions, their feelings and thoughts. They have a tendency to worry in isolation. I hear repeatedly the words, "but it's not about me." And they want to move on to what else can I do for the family member, the spouse, a partner, child. But it's important that we actually have the conversations around how family members are doing. Certainly because research has shown that families, and that includes the individual diagnosed with cancer, experience cancer as one emotional unit. Families are asked to integrate and synthesize large volumes of information, and they're usually having trouble wrapping their heads around the foreign language that healthcare professionals will use. Families are also expected to monitor and supervise care requirements. It is estimated that family caregivers contribute in excess of $5 billion annually to the healthcare system in terms of unpaid caregiving labor. So, I mean, they really do shoulder a lot. And they pick up 25% of financial burdens at end of life. These are their own out-of-pocket expenses in terms of trying to support the loved one at end of life. And Dumont et al., this was a Canadian study that was done that looked at 7 provinces and access to palliative end-of-life care. What else do we know? Oh, sorry, forgot to move that. So family members also experience guilt, frustration, isolation, confusion, fatigue, and they struggle to balance competing demands. It's particularly problematic within the brain tumor population. They're a younger population, ranging between about 45 and 70, with most of them in their 50s when they're diagnosed. I certainly have seen them from their 20s to their 60s, and when we think about the roles and demands that are being placed on them and how they juggle them, it's incredible that they're even able to function. Families can certainly experience guilt, even over asking for help. They feel as if they should be able to do this without having to ask for support. They feel guilty when they actually receive help as well. And there's an expectation that they should be able to step in and manage without that. What's even more interesting are the family members who are the primary caregivers, who are healthcare professionals. Interactions with them have shown that they're often expected to take on that particular role, and I've had caregivers tell me, you know, I just want to be the spouse, I don't want to be the nurse, I don't want to be the doctor here. Just let me be the wife, the husband, or the family member. But as a whole, healthcare professionals will sometimes expect them to step in. When it comes to diagnosing and transitioning across the cancer continuum, families and the patients can be in different spaces and places, which can lead to tension. There will be times when the patient has moved on to acceptance, but family members are still back in denial, and so this can actually create problems because you can see shutdowns in communication when this happens. Certainly the relationship can suffer as a result of a diagnosis of cancer. We know that even high-functioning couples can be thrown off course as a result of the demands of the illness. But there's still a lot more that we need to know, particularly within the brain tumor population, around how the quality of the relationship and preferred coping styles impact quality of life and adjustment effort after a diagnosis of a brain tumor. There's actually really nothing in the literature on that particular issue. So it's certainly important from a clinical perspective that we ask those questions to ensure that things are going okay. We can see emotional distancing from time to time. This is probably not that uncommon. They'll avoid conversations. They'll shut down conversations. When you start probing into some of this, it often stems from a desire to protect. So the husband, I sometimes when I'm seeing a husband and wife, what happens is neither of them are talking, and it's because each doesn't want the other one to get any more upset than they already are. So the kinds of conversations they need to enter into are not taking place, and there's a lot of misperceptions. So then it becomes about helping people to recognize the value of having these conversations and what can happen when they don't. There's a lot of uncertainty within cancer, and definitely I see it within the brain tumor population. And along with uncertainty are a variety of emotions and feelings ranging from anxiety and depression through to grief, isolation, and loneliness. It's often described when you start talking with patients and their family members about waiting for the other shoe to drop. That this and that has taken place. I don't want to hope because, you know, something else is going to happen. There's a lot of what ifs and questioning around that, which can certainly up a person's sense of anxiety. We know that there's an important need for supporting and fostering hope right across our healthcare system from diagnosis to end of life. We look at it from three particular dimensions. So the affective, which is that sense of I have no hope, feeling hopeless, to the motivational, giving up hope, and lack of future expectations. So that's that thinking about it, you know, that I don't have a future anymore. And these are sometimes important conversations, I think, around what is hope, because the interpretation that healthcare professionals may give to hope can be very different from what patients and families assign meaning to hope about, and so what is meaningful for them. I will ask patients and family members, what does hope look like for you? What does it mean to you? And sometimes it's as much as having a good day. The tendency within healthcare is to think that hope means a cure. And that's actually often not the case. Our patients really look at a variety and assign a variety of different meanings to hope. Research is now showing us that patients and families would like to have conversations about advanced care planning and end-of-life options when they're diagnosed. I've had patients come, certainly when they've relapsed, and we're talking about end-of-life issues, and nobody's even brought up the subject of advanced care planning. One particular case stands out in my mind, a former client of mine, who came in one day. She was quite angry, and I was asking what had happened. She had had a seizure and had landed in the hospital, and they had done a further workup, and her disease was advancing. And she was sent home. She wasn't home 2 hours when her husband had said, you know, we really need to talk about a do not resuscitate order. And she became quite angry over this. You know, what are you talking about? Not realizing that the physician in the emergency department and the oncologist had had a conversation with her husband around perhaps putting in place a do not resuscitate order, but nobody had thought to engage the patient themselves in this particular conversation. Or what did she want in terms of advanced care planning? So this became a conversation that the two of us entered into, and she brought back to her husband. Patients wonder why healthcare professionals don't raise these issues. They're waiting for us too, and interestingly, we're sometimes waiting for them to raise it, so we're sort of at odds around this. But it's also important to recognize that while they want to have conversations around death and dying, they don't really care about in-depth conversations. So what they are really seeking is some insurance around that their death would be pain-free, that they would die with dignity. That, as one of my clients had said, I don't want my death to be ugly. And we had a conversation around, well, what did she mean by that? What would that look like for her? And then it became, well, how do you get this information, across to your family, to your physician, and to other care providers? In contrast, caregivers would like to know more about the process of dying, particularly if the location of choice is for the patient to die at home. So they're really, caregivers are really seeking that kind of information around what do I need to be thinking about, what is it going to look like, what should I be doing at this point in time, will I be able to, what needs do I have to have in place to better support this, not only for the patient but for themselves. And they're also wanting to know what's involved after death, and the whole bereavement piece that needs to be attended to. It was interesting. I was having a conversation with a bereavement counselor at our hospital, and he's a wonderful gentleman, and he's saying that even within palliative care he is sometimes excluded. It's like he says, I sort of become the Grim Reaper when I show up at meetings, and it's, you know, he says there's a huge role for him, but he's often ignored, and it is critical for that ongoing support, not just around end of life, but certainly what takes place after for the family. Healthcare professionals fear being blamed. They fear the untaught. You know, I really didn't get enough education in my during my university to have the kinds of conversations I need to have. I don't feel adequately prepared to discuss palliative care with my patients, things like that. So there is more that needs to be done around education within the, for healthcare professionals around certain issues. I know family physicians have spoken to me and said that while they really want to be much more involved with their patients around end of life, their concern is that they won't do a good job because they don't feel adequately prepared. So it's they want to, yet they don't want to. And so how do we better support them so that they're an integral part of that experience? Because they really do know the patients and families. healthcare professionals fear eliciting a reaction. What am I going to do if there's tears? What if they get angry? And I have given whole lectures on anger management. I'm not going to get into it now, but it's not unreasonable when we start talking about disease progression, cessation of treatment, that somebody might get angry. Anger is really sort of a secondary emotion. The one behind it is often fear, and it's related to uncertainty. It's that whole unknowing, so uncovering that. So again, it's important to have those conversations and probe that. They fear saying, I don't know. It's almost as if there's this normative view that healthcare professionals should be all-knowing. Well, we're not, and we need to get over it. I think we've come a long way in terms of recognizing and acknowledging that we don't have all the answers, and that very important knowers of the experience are our patients and families, and coming to talk to them more about it. Expressing emotions. This is something that students often ask me. Is it okay to cry? And trying not to cry. I say, I cry. There are some patients and family members I have connected with more than others, and as they're approaching end of life and we're having conversations, I get tearful with them. And that's okay. Where it's not okay is when the patient or family member has to console the healthcare professionals because they've lost it. But expressing our emotions validates the experience for patient and family. They feel like you truly care. Lack of crying. I mean, some people just don't cry, but a lack of crying, from my perspective, sometimes lets me know that the healthcare professional is disengaging and that there may be other issues that are going on, ranging from burnout to secondary trauma and so on. It can be a symptom of an occupational stress problem. Healthcare professionals, this whole notion of the medical hierarchy, it's not my job, or maybe somebody else is going to have this conversation, I'm not really sure what my role is. We are doing a better job at looking at it. We all are accountable and responsible for various aspects. But we do need to have the kinds of conversations with our patients. It isn't up to other people. And then there's the personal piece as well, that people can be anxious about even thinking about their own mortality, and as a result will not enter into conversations with patients and families, or they've had bad experiences with other family members within their own personal life around death, and so it makes it very difficult for them to have those kinds of conversations. What appears to make healthcare professionals uncomfortable is a need to respond to emotions and suffering. We will frequently get referrals to our psychosocial oncology team for an assessment because somebody was tearful. And really all that was needed was a 5-minute conversation with that patient or that family member around what was going on. Tears are a normal reaction to devastating news and changes in our life. So, taking a few minutes to say, let's talk a little bit more. They're uncomfortable about giving bad news, and some of it we equate with the fact that, we feel like we've failed in some way. They can feel uncomfortable when responding to difficult questions, or such as sexuality, sexual health, and end of life. They're uncomfortable around shifting from curative to supportive palliative intent. And for a whole host of reasons that are complex and interconnected here, work is starting to explore some of the facilitators and barriers around timely transferring to palliative care, and how to more effectively integrate palliative care with primary health care and with the specialists within the acute care setting, so that we're much more involved as a team and are better able to work with patients and families and support them and enhance quality of life. Other things that interfere with our ability to have those conversations may be a feeling that we don't have a good relationship with the patient, or it's patient characteristics and qualities. They don't want to have those conversations. They keep pushing them aside. Might be our own personal, or there can be healthcare professional types of factors that interfere, or the healthcare system itself that intrudes and makes it difficult for those kinds of conversations. And then, of course, there's always the challenges of dealing with family dynamics when end of life is part of the mix. Barriers to engaging in difficult conversations. We can sometimes think that if we bring up the fact that there are no further treatment options, it's a perception of removal of hope. Perhaps more challenging is when to have the conversations. So really feeling uncertain about it. Is it appropriate now? Maybe I should put it off for a little bit longer. If I have the conversation, I'm going to cause further distress. Actually, research is starting to show that it really does not create further distress. It actually enhances and supports psychosocial health and well-being for patients and families to have these kinds of conversations. And then the role ambiguity that I've talked about before around, whose responsibility is it to have those conversations. So what happens when we don't enter into these challenging conversations? Patients and families may experience increased levels of distress, more likely to see depression and anxiety, and challenges with coping. Other unresolved issues may surface and not get adequately dealt with. Perhaps more importantly is that healthcare patient-family relationship can become eroded, and there's a sense of loss of trust when we don't have these kinds of conversations. So it's really important to understand what's blocking us from having them. Strategies to enhance communication. So don't underestimate the importance of human connection, that sense of being present and being in the moment that we all talk about. I tell my students and I tell colleagues that sometimes it isn't about even saying anything, it's about just being there and being, even the recipient of the patient or family's conversation, just letting them talk. But it's about creating that space for the individual and presenting ourselves as having the time, that we don't feel rushed. And I know time pressures are huge within healthcare. We're doing a lot more with less now. But no matter how busy we are, it's about taking those few minutes to have that much-needed conversation and not letting people sense that, you'd rather be anywhere but there because you've got all these other things to do. It's also important about becoming in tune to our own emotional responses, our own values, attitudes, and beliefs. How and in what way these can interfere with our ability to have therapeutic conversations. And we're going to talk a little bit more about this now. One of the important, I think, needs for patients and families is about creating meaning, particularly after a diagnosis of cancer recurrence or when there's a transitioning to end of life. There's a need to make sense out of all of this, and actually it has been, the sense of meaning that is created can actually buffer physical and psychological adverse effects of cancer. A lack of meaning actually can decrease patients and family members' ability to cope. It can block re-engagement in life and increase a sense of futility. There's a sense of loss of control when there's no meaning or purpose in one's life, and that fosters hopelessness. Without meaning, thoughts of suicide can actually come into play as well too, so being attuned to the importance and value of helping facilitate meaning. So we see cognitive, emotional, and behavioral challenges when there's difficulties in terms of making sense out of what has just happened. I've mentioned how it can buffer adverse effects, but it can also lead to demoralization, futility, and powerless ability to cope, sense of futility. I'll sometimes ask patients, and I don't do this with everyone, but when I'm having conversations, particularly after bad news has been given or there's been a recurrence and there's no more treatment options, I'll ask a patient whether they think they're living or dying. And their response is really helpful in terms of what then takes place, because it tells me as well, too, whether there's a sense of hopelessness or hope that's there, sense of futility, lack of meaning around the experience. This is a tool Virginia Lee developed and has published, and part of this is the background to how to make meaning, that there's an ending of this old piece. There's this neutral zone as you start to make sense of what's happening, and then the new beginning, that sense of a new normal, whatever that is from the patient and family perspective. So those three particular phases that individuals go through in the process of making meaning. And it's as simple as this wonderful lifeline which has been used, and some of you may have used this and incorporated in your practice. I think we can all do this. And I'll put it on a piece of paper and I'll ask the individual to draw a circle where they are. And then we're going to talk about what's going on in the here and now, and we'll see where they place themselves between birth and death. I want them to highlight for me some of the wonderful events that took place in their past, and some of the things they're thinking about for their future in terms of goals and priorities, and you know, what would allow them to live out the rest of their life with the least amount of regret, and what would be most helpful and fulfilling for them in whatever amount of time they have left. So some of the things that I've taught students and I will sometimes use with patients and family members is around sharing stories. These can be really helpful in terms of making sense of it. The support group that the support groups across Canada that Brain Tumor Foundation lends support behind and are facilitated are wonderful opportunities for patients and families to make sense out of the brain tumor experience by sharing them, getting feedback from other members of the support group, normalizing various different aspects of it can be really helpful. Keeping a journal, chronicling what has happened can be really helpful. Some individuals, it's around they write down their thoughts and emotions, and then it's easier for them to talk about it after, the thinking around it. Writing a letter to oneself and being one's own cheerleader. I've had clients who have done this, and then they will also create a ceremony, for example, if there was an issue that they struggled with that hasn't been resolved. They will sometimes write a letter to the individual around it and what they would like to see happen and how it made them feel. They don't have to give it to the person. This isn't about giving it to them, and we'll discuss it. And then they put it away and they decide what they're going to do with that particular letter. There's art that can be really helpful. Our chaplain uses photography as a way of helping people to talk about issues and create meaning out of it. Art, photography, the use of metaphors can be really helpful in opening the door to conversations, particularly when people have difficulty in articulating their thoughts, emotions, and feelings. This gives them an opportunity to do that. I think for each and every one of us, and Christopher Johns has written extensively on being a reflective practitioner. Some people may have heard of the term clinical supervision. It's not quite what you think it is. It really is about reflective practice. And it's becoming, I think, much more embedded into healthcare professional practice. I've seen it with medical students. Certainly we talk about it with nursing students. I would well imagine that social workers include it within their practice. And I'm not sure, but I would well imagine that other healthcare professionals, this is a piece of ensuring that our practice is really meeting our needs. But using it when we want to understand why we're having difficulty with entering into certain conversations, it might be really helpful. So there's the piece that Christopher Johns talks about, which is about looking inward. And so what thoughts and emotions were evoked if there was a particular situation that you felt was really challenging, and looking at, so what were those? And then turning and looking outward. What issues seem significant? When you were in that moment, what were you trying to achieve? And why did I respond in that manner? What were the consequences? Not only for the patient and family, but for myself. And how do I know this? Why did I feel the way I did? Did I act for the best? Whose agenda was it? Was it mine? Was it the patient family? What factors influenced my actions? And what knowledge did or could I have had that would have helped me better and informed what I do? And this is not about being superficial. One really needs to become quite critical and, lift up that rock and look at what's underneath it, because we can't change until we truly understand what's underlying some of our reticence around having these conversations. A colleague of mine was telling me she routinely holds workshops for healthcare professionals, all different kinds of healthcare professionals, around sexual health, and she does an amazing job around this. And she said she was running one workshop, and this wonderful person was telling her, she says, I've finally come to the realization that talking about sex makes me embarrassed, and I blush, she says. But what she's now taken to doing is, she says, she'll talk to the patient or the couple, and she'll say, I still have trouble, with my emotions around having this conversation, but I know it's really important. Please, I might blush from time to time, but that doesn't mean that I don't want to continue having the conversation. And she says it really does open the door, because people recognize she's really human, and she's also identified, I have a bit of an issue, but I'm working on it as well, too, and I'm getting better as well. So she's readily recognized where she needs to enhance her practice, and I thought that was quite delightful. Reflexivity also involves looking at previous experiences and how one can do this differently to achieve a more positive outcome, and what can be the consequences when one handles such an approach differently. The whole notion of what could I do differently, and what are the what's the worst that can happen. If you try something, I use this with clients all the time in my practice. Okay, so there's a stumbling block here. Let's look at how could you do it differently, and just even asking that. And it's sometimes surprising how they can come up with the solutions to their problems, and recognizing, while it is significant for me, I really feel like I can do this now. So that's the presentation. Hopefully it was helpful in giving you some sense of what healthcare professionals struggle with, and opening up some options to enhancing your practice in terms of having those kinds of difficult conversations. So I guess I'm open to questions.
Great. Thank you so much, Dr. Sabo. What a great presentation, and lots of really great information. It looks like we just have a couple of questions that have come through, but as I ask them, it'll allow people some time to type their questions if there are any more. One of them was, can you name some red flags, such as abnormal reactions to diagnosis or conversations?
Some red flags around, pardon me? I seem to have lost my screen all of a sudden.
It looks like you're at the end of your PowerPoint presentation.
Oh, there we go.
There we go.
Okay.
So it says, please name some red flags, such as abnormal reactions to diagnosis or conversations. So any suggestions around that, or any examples?
Well, it really would depend on where or how long after the diagnosis. Certainly, because I think that if somebody's just been told they have a stage 4 glioblastoma, I would expect that there's going to be a wide range of emotions that are going to take place, anywhere from tears to anger to denial to, I don't want to talk about it, I need to talk about it, grief and loss related types of issues. What they need to be looking at, or what they need to be thinking about, is checking in every time they see the individual and looking at where are they, how are they doing, if there are signs of disengagement, that's pulling away from, say, their family members, not wanting to be engaged in social activities, so isolating themselves, withdrawing, a sense of hopelessness. They no longer feel like they have any hope. Sense of worthlessness, the kinds of things that for me would be for depression. So doing a screening for that. And part of the Edmonton screening for distress, the ESAS model, is really looking at how are individuals doing at this point in time. So how are the patients doing? And if their institution is using this, and I think there must be at least 10 institutions across Canada that are currently looking at distress screening and have embedded it within their cancer care programs. I would encourage those that don't to have a look at it. You can certainly, it's available online. It's a simple tool to use, and it can really help you in terms of understanding what the level of distress an individual is experiencing and what kinds of conversations need to take place. I think that social workers and nurses and doctors can certainly have the kinds of conversations that are needed for individuals who are, say, between levels 4 and 6, which is a moderate level of distress. And those are the ones that we really worry about within the healthcare system. We're good at capturing those who are truly distressed. They get referred to us. We're going to see them right away. And then those between 0 and 3 are not really experiencing any distress. They're coping well. So again, looking for signs and symptoms of depression. Are they experiencing panic? Are they having difficulty coping and re-engaging with life? Those are flags that I think that need to be explored more. Hopefully that helps.
Yeah, thank you. And did you also, somebody asked if you could, just looking for here, can you put up the strategy screen again?
Oh, sure.
Up again,
yep.
As the question.
Is that the self-reflection one? I think that they wanted. Just a second, I've got to go a little bit further down here. This one here, strategy for healthcare professionals?
I'm just asking her right now.
There we go.
And also the ESAS model, can you just repeat that again or give the spelling of it or the website maybe?
Oh, it's the Edmonton Symptom Assessment Scale.
Great.
They should be able to access that one online, or their institution may actually be using it as part of a screening process, because there is a huge national study that's underway. I know Halifax actually is involved, is one of the institutions involved in it, so I would check and see if that's taking place. Certainly I know Alberta for sure, Vancouver certainly, Winnipeg, I believe, is involved in it, Montreal, Toronto, yeah.
Great. And somebody just had a comment, and she said, I do not think that a nurse not crying alludes to the fact that the nurse is disengaged, burnt out, or from secondary trauma. I rarely cry and have been present in many patients' deaths over many years. I do feel that I'm engaged and I truly do care. I feel that if I cry, that is okay, and if I don't, that it is okay as well. I am sure that there are some situations where the other factors have come into play. The only secondary trauma I can relate to, in nursing school I was taken into a closet and scolded for crying with the family. So I guess different situations, right, for different people?
Mm-hmm. Oh, and I had, yes, she actually did a very nice job of summarizing the points. I did indicate that some people just don't cry. I don't always cry, but it's really about it is okay to cry, because I know students commonly ask me that. At the same time, it is important to recognize that sometimes when we numb down our emotions, that may be a point that we need to start thinking about what's going on here. But I mean, that doesn't mean that they're actually going to go on to develop. I just was identifying that. But thank you to that individual for further clarification.
Great, thank you. And there's a few people who have asked if they can have copies of your slides, Brenda.
Yep.
Normally what I'll do is I'll just get the PDF from Brenda and email it out to everybody who has signed in or who has registered. And somebody also missed the first 5 minutes and was asking who is presenting. So it was Dr. Brenda Sabo from Dalhousie for that person who was asking. And I think that was all the questions. So that's great. Thank you so much.
Well,
and we had a great turnout. We had 47 people signed in.
Wow.
At one point. So really, obviously, a very important topic, very important presentation. And Dr. Sabo gave this presentation as a 3-hour workshop last year in Halifax. So we appreciate you having to condense it down to an hour and for taking time out of your schedule to join us today.
Well, thank you. And if anybody has any further questions, they're more than welcome to connect with me via email.
Perfect.
Okay.
Thank you, Brenda.
So thank you again to everybody. I think I have a sneaking suspicion I was preaching to the choir anyways.
Well, it sounds like everybody was very attentive.
Okay, take care and have a wonderful week, everybody.
Thank you, and thank you, everybody, for joining us today.